I'm going to try to share a little bit of a journey that we've had over the last 33 months at ChenMed, trying to scale out an integrated care model for some of the high-risk, most vulnerable populations in the United States. And just a snapshot of us at a glance, who we are is we're a privately held physician group. I joined in July of 2011 as the number 2 person in the new organization to try to scale out a joint venture with Humana to go into about 6 or 7 U.S. states over the next 2 to 3 years with this model. And our focus, as we talked about segmentation, is low to moderate income, adults over the age of 55, for which we receive reimbursement in a fully risk-adjusted global capitation model with a Medicare Advantage plan. So 90% of our revenue is full global budgets, ranging anywhere from $7,000 US to $30,000 US per patient. And we'll talk a lot about the care model, but if I pick up on the thread earlier today, the essence of our care model is we're trying to spend about 2 to 3 times the primary care up front, and we get 30 to 50% reduction in hospitalizations on the back end. Simple model. Not necessarily easy to implement, but a simple concept. And we've also designed this to scale. So when I joined, there were 5 centers in Miami that were run by a family of physicians that were doing a fantastic job. And over the last 33 months, we've built 36 centers in 8 markets and almost quadrupled our patient size. We're now in the 30,000s and had had similar impact. If I talk about the U.S. context, let me just highlight a couple things around the U.S. that I think it's important to know. I mean, one, to be really honest, is that the primary care physician capability in the U.S. has been deteriorating over the last 20 years, mainly because of an issue with attraction of talent and a migration within medical students to prefer specialties as opposed to primary care. And so if we're going to do primary care right, we really have to address this capability gap and first acknowledge it. In most of the markets, fee-for-service is still the dominant mechanism. Despite government policy, we're almost at the tipping point, but not quite. And with Medicare Advantage, we don't hear a lot about that in policy circles, but Medicare Advantage is where a Medicare beneficiary can choose a private sector plan. And today, 1 out of 3 beneficiaries have chosen that plan. And as the dual eligibles start to go into Medicare Advantage plans, probably 40 to 45% of the costs of Medicare will be in these Medicare Advantage plans within the next 24 months. So a significant amount of costs are going into Medicare Advantage. And the major context for you, I think that's important, is to understand that risk adjustment works. So from a provider standpoint, if I look at different diagnoses or different intensities of patients, the margins aren't different between the low-intensity patients and the high-intensity patients, which means the economists who are at CMS did a pretty good job of doing risk adjustment. There's a lot of issues. Sometimes it doesn't adjust quick enough to adjust for technology, but in general, it's a good model to build a system on. U.S. care is very expensive. You've seen some of the graphs. And then I think on the patients, just understand that the typical patient we see has never had a physician that she trusts. She's usually going around and looking for a different physician every 18 months. That's the typical experience, because I would submit the healthcare system has not been designed around his or her needs. So when I joined the group, we first published an article in Health Affairs to subject our results to peer review. And what this showed is that in 2011, what we were achieving were a couple of pretty significant outcomes already. We were getting hospital days, as measured as hospital days per 1,000, about 35% less than national average. We didn't highlight it, but if you looked at Miami numbers, it was actually about 58% lower than Miami numbers. Net promoter scores for our patients were in the 90s. Our patients were seeing the primary care physician 92% of the time and seeing that same physician and really building up the relationship. And we were getting compliance and adherence from really the 40% to the 80% level. And I'll talk a little bit how we did that at a later time. Now the challenge here is that you take a model that works in one setting. And anybody who's tried to do it knows that it's not easy to take that model and now get it to work in another different geographic settings. What you really have to do is you have to take apart the entire model, understand the philosophy and the values of it, really get a deep understanding of priorities and what drives value, and then rebuild it together so people have clarity on what is done in year 1 and what is done in year 2, because if you're going in a new market, you can't do the 250 things that you need to do right to get integrated care in the first year. You can maybe do 15 things right, but you have to give direction and clarity in what really is important in the model. And so we've had a lot of insights along the way. I think we've also made a lot of mistakes along the way, and we've learned from those mistakes. And let me highlight a couple things. First is results. If I look at the last 2 years, this is a graph of risk-adjusted cost for the entire population, Miami included. We've been able to drive down risk-adjusted costs by about 18% over that 2-year period, mainly, again, through hospital admissions, where last week it looked like our hospital admissions were about 250 per 1,000. As we look at Net Promoter Scores, they've stayed the same as populations have tripled. And we made a couple videos of patients in the last 6 months and what they think. Could you play the video, please?
Doctors and the nurse and the staff are just like my sons and daughters. And that's how I treat them, and that's how they treat me. These people really care about human beings and about their health. That's what it's all about, caring.
What amazes me is the time that the doctor takes with me personally, and I see he does it with all his patients. He'll come in and he'll spend time. He'll ask questions, and he'll let me ask questions. I mean, thorough. He's very thorough, and I appreciate that because I'm not like a number.
My health has improved so much since I've been going here that it's incredible. And the good thing about it is, too, is they have a doctor for everything, and you can see the same doctor. And you don't have to, they take care of all of the referrals that you need and anything like that. They make you feel at home and comfortable, of which is easy because usually when I go to the doctor, when I walk through the door, I forget everything. I don't know whether it's, you're nervous or what it is, but when you go in, she's got her little tablet and she's got all of your records right there, which is really good because if you ask her a question, she can answer it right away. And if you do ask a question, she's sure to give you information to follow up on it.
Well, I love my doctor. My doctor, he is my pride and joy. And he thinks the same of me.
And so one of the things, as we're just trying to get integrated care right, is if you don't get the relationship right between the caregivers and the patients, it's really hard to build a system off of that. But if you do get it right, you can really accomplish a great deal. And what I wanted to do on the next page is to really share with you, some of the key lessons in terms of priorities about building this integrated system. And it reflects a little bit of the sequence in which we're trying to do things. And I'll talk about each of the 6 points in the next few slides. So the priorities really are about focus, culture, information, integration around the patient, and innovation, and in that particular order. And so let's talk a little bit about focus. I was really impressed to see the segmentation work in Northwest London, and just the scope of trying to segment all the patients in a unifying system is very impressive. Now, we basically evolved into this focus of our patient population because of U.S. government policies around Medicare Advantage and around patients. And what we've noticed around focus is the following, is if you really start to design a system around a particular patient segment's needs, you start to realize how much more improvement the delivery care system can really have, because the delivery care system today is trying to be all things to all people. And you really can go down a number of different levels of focus. So let me talk about a couple. So one is that we at ChenMed, we're not optimized around fee-for-service. There have been many people who've looked at workflows in a U.S. physician's office and said that probably about 40 to 50% of the activity is all based around maximizing fee-for-service reimbursement. So we can take that work and throw it away in the trash. So that's a good thing. So we just opened up 50% of workload to focus on patient care. Now, in a risk-adjusted world, you have to capture the diagnoses right, but that's nowhere near as complex as the kind of documentation that has been necessary for fee-for-service reimbursement. Take another example, evidence-based medicine. The typical patient who has 4 or more chronic conditions, which is our focus, and that patient usually generates about 75% of the costs of the U.S. Medicare system. They're on 5 or more medications, and on average, they're taking less than 1 out of 2 pills. So it doesn't matter what the physician is doing if the patient's not taking the medication. And if you look at what's happening, the issues, there's racial economic disparities, and there's deterioration around each of the steps of the way of a pretty complex system if you map it out end to end. So we decided to revamp it because we said our patients can come to the center, but they really shouldn't go anywhere else. So today in a center, a doctor will write an order on a tablet. That claim will get adjudicated in less than 1.5 seconds. There is a pharmacy room. The medical assistant will go. There's pre-filled medications. The MA will do quality checks, get the 4 or 5 refills, bring it to the doctor, knock on the door, give it to the doctor gives it to the patient. So you've done a number of things there. You've re-engineered out CVS and Walgreens, financial copays. You actually have to teach the doctor what the blue pill and the red pill look like, because they haven't had to do that a fair amount before. It gives the patients incentives to bring in medications. Doctors are pretty good often at times about telling the brown bag, but the patients aren't incented to bring in the meds. And now the relationship between the doctor and the patient starts to change, because there's the symbolic giving of medications that got lost in the system that we've evolved to. And so we were able to move in a peer-reviewed article. We submitted it to Society of General Internal Medicine abstract, and it's pending in the Archives of Internal Medicine, that we took adherence from the mid-40s to the low to mid-80s, and we completely eliminated racial and socioeconomic disparities. Because the disparities had nothing to do with the doctor-patient relationship. They had everything to do with the complex process that the healthcare system was making patients go to. Now, I'd like to get compliance and adherence up to 90s, and that may require some different innovations. But again, just really being cognizant of patients' needs and saying, we're going to organize around that patient's needs. So if our patients live 7 miles within the center, we'll bring them in through transportation as well. So focus, I think, on any of these segments, there is 50, 100 different questions that could be answered differently for different segments when you go in. And it's a very fruitful, I think, journey to undergo. The next piece is around culture. And this is what really attracted me to join the Chen family a couple of years ago, because I think they were looking at this quite differently than other organizations. When other organizations that I've seen have looked at the primary care medical home, they said, doctors aren't doing things right. Let's go hire a nurse to come in and do a number of things in terms of process improvement for the practice. But what we're trying to do is we're trying to say, if you close the door in the exam room and you have the doctor and the patient, as in our logo, how can you make sure that you get the optimal outcome without any other interference? And I would submit to you, being a doctor, that doctors are the same in terms of management philosophy as any other professionals, whether you're a rocket scientist, whether you're a lawyer, whether you're a software engineer. You don't want to be micromanaged. You want to have a common set of values. You aspire to perform better as a professional. And some of the principles about transparency of outcomes, collaboration and competition, and really creating a culture that raises all tides is the key thing to unlocking physician performance. And so we've tried to really build that physician culture. And I'll just lay out a couple of things. One has been in a market with, again, the admitted gap in physician capabilities. We said what we had to get right were 3 attributes. If we're taking care of chronic complex patients, we said the doctor needs to like to take care of those chronic complex patients. Probably eliminated about 40%. Because in the primary care system in the US, there was high volume, 30 to 40 patients a day sometimes, and a lot of doctors got used to seeing high volume and not necessarily spending 40 minutes with a complex patient. The second thing is it's a relationship business. So physicians need to be good with having excellent relationships with their patients, with each other, with the team. And so that's an attribute. And I think the third piece is around being accountable for the individual performance. And if I give a screening question, it would be if you look at preventable hospitalizations, we could all agree there are probably 10 reasons for any hospitalization that could be prevented. And probably only 3 of them lie in the direct locus of control of the physician. We want a physician who looks at those 3 and says, I want to do something about those first, and doesn't look at the other 7 and say, that's the fault of why the patient went into the hospital instead of stayed out. And we do a number of other things around professional development. So we just had reviews of all the physicians, with a pretty detailed professional development plan. Many of them thanked me the last week or 2 because it was the first time in a career that 15 or 20 years that they've ever gotten detailed feedback saying, this is what you need to do to improve as a clinician. And we're actually going into the exam room to observe the physician-patient interaction, because how else are you going to know how he or she is doing unless you actually observe it? So culture is really important. This is a graph to just show the physicians in our group. We rated them on a synthesized scale of 1 to 5 in terms of outcome data, sort of hard factual outcomes. And it takes a while to develop as a physician in this model. So there is an investment that is required of usually about 2 to 3 years until you really start getting the outcomes that you desire. And so it's a different apprenticeship program, if you will, for physicians who are in this program. The third piece is around information, and we're having a outbreak session later on information. Let me just make 2 points. I think point 1 is that when you start to look at managing under a global budget as opposed to activity, I think the workflows are 100% different. And most of the time, the technology, at least in the US, is not engineered to allow that workflow to happen. So as an organization, we've decided to build most of our technology ourselves. And that has led to a number of successes. It's also led to a couple of pain points, as you can imagine, in implementing a system that is now cloud-based using Microsoft.NET. But what I would also say is, as you're looking at any kind of segmentation piece, oftentimes the thought process around who is using the information is not as practical as it needs to be. You need to think about, what is a medical assistant going to do? What is a social worker going to do? What is a case manager, a physician, and the leadership of the market going to do? And all of those information requirements are different, but I would submit that there are a number of off-the-shelf tools that, if the data structure is sufficiently intact, you can lead to a great deal of activities connected to data very rapidly. I don't think you need a large startup time. As we've gone into other markets, one of our challenges has been around the model of integration. And it's been, as you can imagine, if we're just starting, what we're not going to do is we're not going to start to negotiate with a large health system who has 60% of the market share around a whole number of relationships and activities. Instead, we've been trying to really integrate, that's forced us, if you will, to integrate around the patient and really start to work our way out of the primary care relationship and say, what are the exact right relationships to get right, whether that extends to the hospitalist or the folks who are making decisions in the skilled nursing facilities or looking to get our own boots on the ground in the home. And what we look to do over time is almost build a virtual integrated system so that there are preferred specialists who we're working with. We're trying to bring those in to conferences to discuss cases, to build the relationships, again, with the physicians. And just as a final note, if we look at the whole issue of trying to take care of a specific segment of the population care better, I would submit that we're on a journey that we've just really begun. If it's a 10-chapter book, I say to my team, we're at chapter 1. This page sort of outlines maybe a 3-phased approach, where I think in the U.S. we can get our total cost of care reduced by 30 to 40% over a decade. We're probably just in the frame on the left-hand side. Some of the things that are on the right-hand side that are much harder to do when it talks about primary prevention, really getting diet, exercise, sleep right in patients, and learning how to do that more effectively within the medical model. I think we've really only just begun there. Areas where behavioral integration, the right hospice and advanced care planning, that we still have a big gap in our population where we think we can do a lot better. But we think it's been an exciting journey and look to partner with like-minded institutions as yourself and share how we're doing. Thank you.